I'm Dr. Hong-Shik. Today I'm going to talk about cause and solution to a situation where the patient complains about prosthesis. After providing prosthesis, sometimes patients complain about discomfort. There are many different types. Most prominent cases are as shown. Food impaction. The patient chews on tongue or cheek. The patient has difficulty chewing. The patient is unsatisfied with the appearance of the tooth. Sensitivity and chewing upon mastication as well as sound. These complaints are some of the common complaints. I'm going to look at the cause and possible solutions. First is reason and resolution of food impaction. One day a patient came in. The patient said that the patient received prosthesis from a nearby dental clinic and food impaction was so severe the dentist provided crown multiple times. However, food impaction situation did not improve. The patient had to go overseas. However, the patient was severely concerned over this issue. On the X-ray, endodontic treatment has been done well, and when you do flossing around the crown, the contact points were not really bad. However, the patient was experiencing severe discomfort and crown was removed as shown. After that, cord was placed. In order to expose the crown margin accurately, laser was used to cut out gingiva. Additional prep was done. As shown, the left is before removing crown. This is after prep has been done, after removing the crown. What is the difference? From the margin to the adjacent teeth, the gingival space is quite wide. New prep was done, margin was set freshly. And from the new margin to adjacent teeth, the distance has been reduced. What this means is that the margin of the original crown was too short and was quite superior. Scanning was done as shown. If you look at the line of the crown, in the case of the original crown, the crown appearance starts off quite superior and it is quite unfavorable in terms of food impaction. As I made new crown margin, I made it so that the crown appearance comes more inferiorly. As shown, the crown was designed once again and occlusion was made. Finally, crown was refabricated. I set the temporary crown. What is different in terms of crown form before and after treatment? Before treatment, if you look at the crown, the palatal cusp is excessively over-contoured. After treatment, this has been addressed and improved. The most important reason is because tooth prep was insufficient. In my case, on the day I set the crown, I do final setting. However, in the case of this patient, I wanted to check whether the food impaction problem was resolved. And I had the patient use a temporary for a week. After a week, I removed the crown, which was set temporarily. Although the issue of food impaction improved significantly, you can still see that the problem persists here. As a result, I added more porcelain on the proximal surface right away and had the patient use it for a week again. A week later, I asked the patient to come back to check whether the issue of food impaction persisted. After a week, you can see that food impaction issue has been completely resolved. I did final setting like this and completed the case. This is the final crown. Before treatment and after treatment, there is quite a difference in crown appearance coming up from mesial and distal crown margin. The crown length on the buccal side has been elongated. The crown appearance on the palatal side, which was originally over-contoured, it has been resolved as well. Second issue is related to chewing tongue and cheek. After being given new prosthesis, the patients complain that they chew on their cheek or teeth. If there's wrong overjet in the buccal side, they chew on the tongue. And if the tooth contour is done badly, food impaction can occur as well, along with cheek biting. If overjet and overbite on the lingual side change dramatically after prosthesis is delivered, sometimes a patient talk about tongue chewing. When you design crown, you need to reflect the appearance of crown before treatment, which the patient feels more comfortable with, and that would be more ideal. In this case, crown was provided in number 17 and the patient is complaining of cheek biting. I looked at the appearance of the crown and the design on the buccal side, it is over-contoured. Compared with dental system, when the buccal contour is over-contoured, in adjusting it, exocad is slightly more difficult compared to dental system. Because of the area that was over-contoured, food impaction occurred. I improved the design and crown was refabricated, and the patient's discomfort in regards to cheek biting was improved. If position of implant is slightly lingually inclined and if the appearance of cervical area is like this, the overjet overbite relation the patient had before treatment has changed negatively. And after treatment, there can be complaints regarding food impaction along with cheek biting. And there's high possibility of that here. The third complaint that patients make a lot is low efficiency of mastication. After receiving crown, the patient says that unlike before treatment, mastication is not done properly. When you hear such a feedback, it can be quite baffling. Let's look at this case, number 17 and 47. When chewing, the patient complains that there's sensitivity and pain. Endodontic treatment was done and crown was provided, but the patient continued to complain about being unable to chew properly. The patient also said that the center of the crown was too flat compared to before. The patient continued to experience sensitivity in the tooth which did not go through endodontic treatment, therefore endo treatment was provided for both teeth. Why is this patient experiencing this problem? I looked at the crown design file once again. I reviewed it. If you look at number 17, the crown, the cusp and central groove's height is almost the same. It's very flat. Number 47, the cusp and central fossa is flat. Number 17 and 47 were prepped at the same time and designed at the same time, and the cusp form and central fossa form was designed so that it could be engaged. That's probably why it became flat. It was then that I thought that I needed to look at what the patient's original central fossa and groove looked like. So comparison was done. Before treatment, you can see that there is quite a height difference between cusp and central fossa. It's quite curvy. After new crown was provided, the curve between cusp and central fossa is basically gone. It's the same for number 47 as well. Before tooth was prepped to provide crown, if you look at natural tooth, there is very significant curve between cusp and central fossa. However, in the new crown, there is very little height difference between cusp and central fossa. I observed this as I reviewed. In order to restore the original cusp form before treatment, new crown was designed. Central fossa was additionally adjusted. I made the design of cusp and central fossa more curvy. The same process was taken for number 47 as well. In order to restore the original form, additional adjustment was done and crown form was improved. New crown was fabricated, and I asked the patient to chew using this and provide an evaluation. The patient provided feedback that the function has improved significantly. Fourth complaint, the patient can complain about the tooth appearance. In the case of this patient, upper right and lower right crowns were removed and implant treatment and crown prosthesis needed to be provided. After implant placement, final prosthesis needed to be delivered and CAD program was used to design custom abutment and crown at the same time. Custom abutment was placed and crown was placed as well. The patient provides the following feedback. When I made the first crown, the patient said mastication cannot be done. Second time around, the patient said the tooth was too small. Third time around, the patient said it was too short. Fourth time around, the patient said that the tooth did not look like this before. Was the patient the problem? When the patient demand is as detailed as this, in order to address these issues, what should we do? Dental system was used to design the crown once again. I designed custom abutment and crown together. After designing the crown, I did not make final prosthesis, but using 3D printer, I printed out temporary restoration, and along with custom abutment, I tried it in. Temporary crown was connected to custom abutment and it was tried in, and reflecting the comment made by the patient, I adjusted the design once again. After the patient said that the crown appearance and form was satisfactory, based on the approved design, final zirconia crown was milled and coloring was done. Final prosthesis was completed in this way. If patient demand is very detailed, in order to satisfy such demand, there are a couple of requirements. First, you need to check what the original teeth looked like. You need to have records or images of what original teeth looked like. In this case, it is much more easier to restore teeth. However, if you don't have these materials and information, there can be conflict between patient and the dentist because they may have different subjective opinions. It can be quite embarrassing, and there can be a high possibility of such problems occurring. Second, I believe more so than anything else, it is most important to provide the look and feel of the original teeth which the patient has become accustomed to. Restoring the form of crown the patient used to have is very important. Finally, these processes, the original teeth the patient was accustomed to, in order for us to have knowledge about this, we need to take images, pictures, and records and keep them. This is very important. One of the most common complaints is discomfort upon eating. There are two possibilities when the patient complains of sensitivity and pain upon mastication after receiving crown. You need to determine whether the pain is because of endodontic problem or because the occlusal points of new prosthesis are high. You need to figure that out primarily. If it is because of pulpitis, you need to do endodontic treatment. If it is because occlusal points are high, you need to do occlusal adjustment and check whether such sensitivity is relieved before you do endodontic treatment. This is the final complaint, grinding sound upon lateral guidance. After providing zirconia, especially when patient chews sideways, at times the patient can hear a sound. This is because something is hitting the crown when lateral guide is done. Therefore, such complaint has resulted. As mentioned earlier, you have to use dynamic occlusal function in designing crown and remove what is necessary using the guide function. I would like to emphasize once again. This is the conclusion for today. In general, major complaints expressed by patients after receiving prosthesis can be divided into 6 categories. Food impaction, cheek biting, inability to bite properly, unsatisfactory tooth form, sensitivity, pain, and sound. These 6 symptoms need to be addressed using digital workflow. This is a very important tool to address it. If you have designed a crown using digital workflow, there must have been reasons for such feedback. You need to figure out what those reasons are and adjust it to provide a satisfactory prosthesis for the patient. You can provide an improved prosthesis to the patient. Digital workflow is essential in improving patient satisfaction in these areas. This is the end of my presentation, and we will have Q&A session to address your questions. First question: how do you find out objective cause for the subjective symptoms expressed by the patient? If the patient complains of food impaction or cheek biting, inability to chew properly, I always look at the design files. I check and I look for possible elements that could cause such symptoms. I create a problem list and I remove them one by one. And this is the way I provide treatment. By removing objective causes, in a lot of cases, such subjective symptoms or complaints are addressed. Second question: from the lab, you only get final results, so it is very difficult to find out the root cause. In order to prevent frequent remake, what should we do? If the occlusion is high or contact is not proper, when you adjust the occlusal surface or proximal surface, you can look at those figures and make some changes based on the feedback. If there are other problems related to design, you need to get the design file from the lab and look for hidden causes. Personally, I believe you should be able to find them. This is the end of my lecture. I hope this lecture was a lot of help in reducing patients' discomfort after providing prosthesis. Next time, I'm going to talk about how to design efficiently using pre-prep function. Thank you for watching.